of Professor Jambalingam sir. The topic is current trends in hypertension management. Over to the presenter.
Medical director, medical superintendent, and other consultants, and my dear PG students and nursing staff. For this month, we are giving the 3 topics, 10 minutes each. So it will be like a rapid fire round. First topic will be current trends in hypertension management. Recently, the sprint trial showed that the BP level cutoff should be lowered to 130/80, so that many people are diagnosed as hypertension, and lifetime prevention measures and treatment measures can be started. So many new things are coming up. Similarly, dipping of BP, nocturnal dippers, lack of dipping, they all contribute to resistant hypertension. And similarly, morning surge of BP results in strokes, heart attacks. So you have to give the drugs most of the time in the night, so that there will be a good effective BP control. Statins, antihypertensives, along with aspirin, antiplatelet agents, anything if it is given as a single pill combination, that is the current trend, so that the CVAs and heart attacks can be prevented. So to talk about all these things, my PG will be talking. Dr. Akash will be talking.
Good morning, everyone. I am Dr. Akash, first year general medicine resident, presenting on behalf of Dr. Jambalingam sir, head of the Department of General Medicine. So my topic is current trends in hypertension and resistant hypertension. So according to recent guidelines of 2017 American Cardiology and American Heart Association and 2023 ESH guidelines, the similarities are office-based measurement of BP and home BP monitoring and 24-hour BP monitoring. Each of the 3 has a unique significance. That is, there will be variability in the BP between hour to hour and during the day and between first visit of the patient and the next visit. So it is called short-term variability and long-term variability. Then beta blockers were no longer used as the first-line antihypertensive medications because there is a concept called central aortic blood pressure. It is the pressure in the aorta which is measured using an invasive technique. So when there is more central aortic blood pressure, the degree of target organ damage is achieved very fast. So the consequences of the hypertension will be achieved at the earlier age. So beta blockers are increasing those central aortic blood pressure, and hence it is not used as a first line management of antihypertensive medications. Then a single pill combination therapy is used as first line strategy. That is a combination of AC, angiotensin converting enzyme inhibitors or ARBs with calcium channel blockers or diuretics as first line therapy. So the differences is ACC guideline says that to diagnose as hypertension, BP should be more than 130 or 80. Then ESH says an extra 10 mmHg in systolic and diastolic blood pressures. So it is very easy in 2017 ACC guidelines that everything is cutoff is similar in all age groups, but it is slightly different in ESH guidelines. Then as mentioned before, the short-term variability is 24-hour ambulatory BP monitoring and home monitoring. This is between next 2 sessions, long-term variability. So Sir told the importance of nocturnal dipping. We can see that during night time there is a decrease in 10% in systolic as well as diastolic blood pressures, and absence of this dipping is seen in CKD patients. So we can, by using studies, we found that when this dipping is absent, it accelerates the progression accelerates the target organ damage, like increased risk of stroke, MI, etc. Then using 24-hour ambulatory monitoring, we can this white coat hypertension, that is when the patient comes to the hospital, there will be increased in due to more anxiety, there will be increase in blood pressure, and masked is the opposite of the same. Then this nocturnal dipping, everything can be monitored using this 24-hour ambulatory monitoring. Then, as I told, in sprint trial have conducted in population age group more than 50, two group was separated. Those with one group was given intensive therapy, that is target was kept as less than 120 and the other group as less than 140. Those with the intensive care has a lower risk of mortality due to cardiovascular diseases. So the disadvantage of this study is that in intensive therapy, the chance of hypotension and syncope was more. Then, as told prior, CABP monitoring is not only a best marker for target organ damage, it is also a predictor of target organ damage. Before the target organ damage, that is like left ventricular hypertrophy, microalbuminuria, this is more superior to it. Before the organ is damaged, we can predict that the patient is going to have this in later stages. And arterial stiffness is one of the reasons for increase in central aortic blood pressure, and this arterial stiffness and hypertension is a vicious cycle. When the age increases, we know that central arteries are more elastic in nature and peripheral arteries are more muscular. When the age increases, there will be fibrosis of the central arteries, which increases the pulse wave velocity, and it directly transmits the pressure generated from the heart to the end organs. So that damage will be more in those conditions. So, as told again, previously, beta blockers augments the blood pressure. Then coming to the management, first we should know whether it is an essential or secondary hypertension. 90% of the hypertension is essential, that is idiopathic, no any primary causes identified, and the remaining 10% is secondary causes. And coming to the treatment strategy for uncomplicated hypertension, that is an isolated hypertension, we will just start with lifestyle modifications like low diet, etc. And then we will go for drugs like either AC or ARBs plus CCB or diuretic at low doses. Then the next step will be titrating of those drugs. Then comes the third drug, either CCB or diuretic. So if the BP is not controlled within the use of these three drugs at maximal tolerated doses, and out of three, one must be a diuretic. So if all three criteria is satisfied, the patient is tagged as resistant hypertension. And the most common cause of resistant hypertension is non-compliance of the antihypertensive medications by the patients. So beta blockers are not indicated in first line therapy, but in certain cases it can be added as a second or third line drug. Example, in cases of heart failure, angina, and post-MI, atrial fibrillation, etc. So, a complicated hypertension with CAD, we can use beta blockers as second line drug. A systolic heart failure, we can use beta blockers. Then in CKD, instead of beta blockers, you can go for the standard therapy, either ACE plus calcium channel blocker or a diuretic. In COPD, we can use either ACE or ARB plus a beta blocker which is pulmonary friendly, that is bisoprolol and nebivolol. This nebivolol is having a tendency to lower central aortic blood pressure when compared to other beta blockers, so hence it is used here. Then resistant hypertension, as told earlier, the most common causes for secondary hypertension is primary hyperaldosteronism. So newer drugs are targeting the aldosterone mechanism, and so we target, this is renin angiotensin aldosterone, we target aldosterone by either decreasing the production of aldosterone or blocking at the receptor level, so that we can excrete more amount of sodium and water loss, thereby decreasing the BP. So the targets are right from production of angiotensinogen, we can block there. Then we can block at the conversion of angiotensin 2 to 3, because angiotensin 3 will eventually activate vasopressin, and we all know that vasopressin increases the blood pressure. So that is peptidase A. We can block there, or either we can block at angiotensinogen production level, or we can block at newer targets is that endothelin. Endothelin is present over the vascular endothelium. It has two types of receptors, A and B. B has a mild dilating property, but using the combination of A and B, the predominant action will be dilating property, so that BP will be reduced. And another target is like ANP. We all know that atrial natriuretic peptide, that is when BP or volume increases in our body, we have natural tendency to produce ANP, that is atrial natriuretic peptide, that causes natriuresis, sodium and water loss, and hence BP decreases. So these are the drugs. And since we are blocking at the right from beginning step, it has a systolic blood pressure reduction up to 20 millimeters of mercury, and these are at last few steps, and hence the reduction in BP is very low. Then these are the newer drugs, and we have non-pharmacological approaches like if we decrease the sympathetic activity in our body, we can decrease the BP. So renal denervation can be done using radiofrequency ablation, and that causes a systolic BP drop of 7 and diastolic BP up to 3.5. Then this is a newer technique of baroreceptor stimulation. Normally we know that baroreceptors are activated only when we are when our blood pressure is lowered or volume is reduced. So this in case of in patients with hypertension due to arteriosclerosis, the expansion of carotid vessels is reduced, so that the sensor, that is baroreceptors stimulating capacity is reduced, so that brain thinks that there is low volume and more sympathetic drive is there. So we mimic the activity of baroreceptor and we decrease the sympathetic activity. This has maximum reduction in systolic BP in resistant hypertension, like up to 36 mm drop in blood pressure, systolic blood pressure. And this is similar approach. Instead of stimulating externally, we use a baroreceptor endovascular technique. In this, this causes receptor deformation that increases the sensitivity of the baroreceptor, and hence there will be up to systolic BP can be dropped up to 20 and diastolic BP up to 10. Thank you.
I thank Dr. Akash for his nice talk. One important thing is in heart failure, angina, or MA, the beta blockers become first choice drugs, need not take the second choice. But they are the regular uncomplicated hypertension, they are the fourth choice. Dr. Binu.
Sir, my only doubt, Dr. Jamblingam sir, see this hypertensive bleed, brainstem hemorrhages, we would like to bring down the BP fast. So using, of course, calcium channel blockers, and still we feel this ARB, etc., acting little late, so that we would like to use clonidine, clonidine. But in our stroke journals, they have said clearly, large bleed, brainstem hemorrhage, better not to use clonidine in the acute phase. If you use that, that acts centrally and inhibits the mammillothalamic tracts, so that the further decline in the level of consciousness. What's your take on that, sir? Because to be very frank, I'm using left and right clonidine to bring down the BP in the acute phase.
We use only ACE, ARB, clonidine lit old-fashioned drug as on today.
But still, we are getting good control with that, sir.
We are getting control, but it's centrally acting drug
Centrally
can
acting.
interfere with your conscious levels, and this withdrawal effect may be there. But nowadays, all the books, the new drugs on ACE, ARB, yeah, beta.
Beta blocker, sir. Another thing is already because of ICP, raised ICP, heart rate is low.
Yeah.
Further using beta blockers, further get bradycardia. Now we don't know whether bradycardia is due to the disease or due to the drug.
That is usually ICT. For that, correction of intracranial pressure is more important with steroids, diuretics, mannitol. That will reduce the beta.
Yes, sir.
heart
I agree, sir. Again, I am asking the same question in the reverse way. Which is the fastest drug which can reduce the BP in a hypertensive crisis like this with brainstem hemorrhage?
Yeah.
Because in acute stroke, we have been talking, don't reduce the BP fast, and then we can bring it slowly and try to keep it around even 160, 100 first 24 hours and take your own time and reduce BP. When hemorrhage is not so, try to bring down the BP to 130 and little below if possible.
Yeah.
Then only you can control the hemorrhage. So, which is the fastest drug which can act to control the BP?
Nowadays,
Parental IV.
the parental IV.
That's for a short while, sir. But persistently, if you give that Levitlal, if you give, it acts for half an hour, 1 hour, then again BP goes up.
After that, you can tide over with the oral drugs because oral drugs has unpredictable form of kinetic profiles. Whereas parental, you have control.
No. Parental only we are using. My question is, parental acts for some time. After that, again BP goes up.
That you have to maintain the.
Tide over with an oral, overlap with an oral drugs.
That's what we use is Levitlal or NTG drip.
Yeah.
Bring down the BP and this calcium channel blocker.
IV and enalapril.
Yes, sir. We don't use that IV enalapril. So that's a good suggestion.
IV Esmolol is also available.
Beta?
You know.
Nitro.
That's what.
Nitro.
That's what I'm telling you.
Severe.
Metoprolol.
Sir, IV nitroprusside is there.
No, sir. We don't use that. Nitroprusside. We don't.
Close monitoring.
Close monitoring. What we use it only NTG to bring down the BP. Aruna wants to say something. Hanga.
But nitroprusside is better than other. Like I have stopped it. Like but nitroprusside is so role in certain areas. Dissections. This is IV.
No, I am asking about specifically in hypertensive hemorrhage. Especially brainstem is knocked off, large ponton hemorrhage. You have to bring down the BP. What to use? The only problem with our Coldin is it causes depression of the mammillothalamic tract and further reduction in the level of consciousness. Thank you, sir. So IV metoprolol.
IV metoprolol,
IV metoprolol.
enalapril.
Yes, sir. Yes.
Another thing is there will be sympathetic vasoconstriction that will cause acute rise in BP even if the BP patient is normotensive. That factor also must be taken into consideration. If you wait for 48 hours, the BP usually drops, but our aim should be maintained at a level of 180-100.
Sir, what is the role of meditation, cutting the salt, exercises, and is essential hypertension due to genes?
Yes, sir.
90%.
Okay. So sir has given the question and answer. As we know, hypertension is also a lifestyle disease. So all lifestyle diseases, the main treatment or initial part or most important part of treatment is lifestyle modification. Without lifestyle modification, there is no treatment for hypertension, diabetes, obesity, dyslipidemia.
No, yes. But before this, all this newer, the ACC, AHN, ESH, more or less following the footsteps of JNC.
I think, and the another important point is combination of ACE and ARB or either of it along with the aldosterone antagonist is not generally allowed because there is increased incidence of hyperkalemia and acute kidney injury, which can even lead to dialysis requiring scenario, particularly in the perioperative period. Right.
So, thank you, and we have a next presentation from the unit of Dr. Bino, sir. Over to presenter for doxycycline induced hypoglycemia. But you have already given an answer in the title. Okay, we'll see.
He's going to present it as two sessions. In part 1, he will talk about generally about sepsis and use of procalcitonin. Then we will go to the commonest, widely used or misused drug and its rare side effect.
Good morning. Okay, so I'm going to talk about a certain diagnostic or to say a de-escalating marker in sepsis, procalcitonin, and as a second part I'm going to talk about antibiotic-induced hypoglycemia. So Coming to the problems in sepsis, sepsis is usually very non-specific, and a lot of symptoms of sepsis overlap with other diseases like heart attacks or DKA or something. And there is a heterogeneity between the patient population who experience sepsis. While the older people, they decompensate very fast, and the younger people, they just have a fever and decompensate later. There is also rapid progression in sepsis, and there is until date there is no rapid or specific diagnostic test for sepsis. And we have a lot of questions when treating sepsis patients. Should I stop antibiotics? Is the disease resolved? Will this come back again? Will my patient need ICU care later? And also there's a growing trend in post-sepsis syndromes. Usually people who spend a lot of time in ICUs tend to experience this chronic fatigue, post-traumatic stress disorder, and a long-term cognitive impairment. So people started to use some composite measures. They started to make composite measures like SOFA, QSOFA, NEWS2. These are all based on certain points given to certain markers. So they make a composite measure to assess to use it as a diagnostic or a prognostic marker, but they also have problems. As you can see, QSOFA has poor sensitivity, and SOFA takes a lot of time to calculate. And news scores elevated. They are elevated all the time, and they seem to produce an alarm fatigue in the healthcare providers. A lot of audits were done, and they find out people have elevated news scores all the time, and then the nurses were always seeing this, and they are desensitized to it. SIRS is very late and very non-specific to use in sepsis. Okay, so a lot of organizations came up with their own definitions, their own guidelines with a lot of variations. The NHS even went to the extent to say that if your patient simply looks ill or they have a fever, you think of sepsis. And they even outsourced this from the doctors to the nurses, and they they changed the infection control nurses to a new sepsis nurse whose entire job was to clerk all the patients in the ward and ask the golden question, can this be sepsis, and then do the sepsis bundle for those patients. So that was the level of that was how emergent sepsis was considered to be. And so when in the late 90s, people noted a certain phenomenon that procalcitonin, which is a precursor to calcitonin, it was being raised in post-operative patients with having thyroidectomy. So this led so how was that even possible? Because only the C cells produced procalcitonin. That was the level of understanding then. So people started studying on that. Several cytokine studies were done, and why the procalcitonin gene is being upregulated in sepsis, it was being investigated, and we still don't have a definite answer yet. They later found that this procalcitonin value was correlating with the WBC count and CRP raise, which was happening later, and the procalcitonin was rising earlier. And the current understanding about procalcitonin is that bacteria and the lipopolysaccharide and certain cytokines that they induce the procalcitonin gene in other areas of the body, including the liver and the immune cells. So that produces procalcitonin, but it is not efficiently cleaved into calcitonin like in the thyroid. So the main source of calcitonin was still the thyroid, but the procalcitonin was being produced by cells all over the body. We found that the half-life of procalcitonin was about 24 hours. And another important thing is that it wasn't altered by giving exogenous steroids or in viral infections, where the primary cytokine would be interferon gamma. Okay, so these are the studies that were done, with major studies done with respect to procalcitonin. Before 2013, there were several studies. They were selling it. They were saying it's a good diagnostic marker, and you can use it to find out post-operative anastomotic leak. That was the idea back then, and it was all changed when the Surviving Sepsis Guideline came out in 2021, which said that it shouldn't be used as a diagnostic marker and only clinical criteria should be used. And later the IDSA guidelines recommended the discontinuation of antibiotics based on procalcitonin. So these were all weak studies, and the later PROACT, PRORATA, SAPS trial, they were larger and more recent studies. They were talking about the mean antibiotic duration, which can be reduced by using procalcitonin, and they found out a majority of the studies found that the adverse effects weren't as high when terminating antibiotics earlier based on procalcitonin levels. And as a use in prognostic marker, 2 trials found that decline is equal to a good survival and non-clearance is a bad survival. There were strong evidences, and there were also other studies which said pancreatic necrosis can be predicted when procalcitonin levels stay high at 96 hours. This is a temporal profile of procalcitonin. This is a study which compared people who received appropriate antibiotics and inappropriate antibiotics for sepsis. So as you can see, both of them had an increase in procalcitonin about around 16 hours, but it started to decline when people were receiving appropriate antibiotics from the 16th hour, while it was increasing in the people who were receiving inappropriate antibiotics. So what we can take from this is that we can know when to repeat procalcitonin to see whether we have given an appropriate antibiotic or not. See, the maximum gap between the appropriate and inappropriate antibiotic use, you can see as between 24 and 48 hours. So that is a time when probably we can repeat and see if it's still elevated, that we have not given an appropriate antibiotic. They also compared with the CRP levels, which did not differentiate when used less than 48 hours. Body temperature also, even the people who were receiving inappropriate antibiotics, they are also getting fever spikes. And if we change the antibiotic course from an inappropriate antibiotic to an appropriate antibiotic during the illness, they found out this procalcitonin level will become unreliable. So that was another take. This is also a comparison of the various markers that we can use in sepsis. You can see that procalcitonin is the most specific and sensitive to bacterial infections, even more than direct cytokines like interleukin 6, 10, or TNF. They were elevated earlier, but it was not very specific. Even lactate is very low sensitivity and specificity for sepsis. It gets elevated only when there is a tissue hypoperfusion. Okay, so why don't I just give a few more days of antibiotics? This is the temporal profile of how resistance developed in Salmonella typhi. So you can see that within 20 years, it had evolved from chloramphic efficacious to chloramphic or widespread resistance. The same way, every antibiotic that was introduced in less than 20 years, resistance was developing and becoming widespread. So it seems to me like it followed how when gasoline replaced steam engines around the same time, and just like every drop matters in fossil fuels, every day of antibiotic also matters. So, and over to my second topic, drug-induced hypoglycemia. This is a patient that we had who had an acute infective COPD exacerbation with sepsis. He was on home BiPAP. He was not a diabetic, and we started on piplusin, tazobactam, and doxycycline. And in a few hours, she developed a hypoglycemic episode and seizures also. And she was later intubated in the MICU. And we were continuing to give doxycycline, and she was having recurrent hypoglycemic episodes for about 4 days. We were correcting orally and intravenously as well. we were looking for the cause. The infection was settling. We evaluated all the factors. We even did the C peptides was normal. The cortisol was within limits. So when we reviewed the literature, we saw that this is probably a side effect of doxycycline. We decided to stop, and resulted in no further episodes of hypoglycemia. And about some antibiotics leading to hyperglycemia, fluoroquinolones and cotrimoxazole, they are very similar to sulfonylurea in terms of structure and function. So they cause hypoglycemia sometimes. And quinine is a known cause of hypoglycemia in intravenous use for malaria. And pentabidine is another antimicrobial which can lead to both hypoglycemia initially and later hyperglycemia. So, but tetracyclines, where the mechanism was not fully understood, but we only have a few scattered case reports that say they cause hypoglycemia. As a concluding remark about procalcitonin, this is initial clinical assessment is mandatory, and you're going to decide whether the bacterial infection is uncertain or it is highly suspicious. If it was uncertain and if you find the patient is having a mild infection and is going to be treated on an OPD basis, that is the only time that you can withhold antibiotics. And in no other situations, irrespective of the procalcitonin levels, we always start antibiotics. It is not procalcitonin is not something to be used to decide whether to start antibiotics or not. So if we did a procalcitonin, it is better that we repeat procalcitonin. In unlikely situations, we can repeat within less than 24 hours and stop the antibiotic if it is still low. And if bacterial infection is likely, then we can repeat within 24 to 48 hours. And if there is only a 80% drop, we can stop antibiotics. So you can go on repeating every 2 days or so and look at the levels, and if there is a drop, then you can stop antibiotics. That is the principal use of procalcitonin. So that concludes my talk. Thank you.
Code sepsis. If we formulate and get a protocol, that will help many patients.
It's high time that we start code sepsis also, because here also door to needle time is very important. If we don't start antibiotics initially, we may miss the bus.
Even if you start a wrong antibiotic within a time, still the survival is better. That is what the surviving sepsis guidelines. Golden hour. So that is there with the surviving sepsis guidelines for many years. The question to you is how to say that it is exclusively say that it is doxycycline-induced hypoglycemia, because a lot of bias factors are there. One, that patient is not diabetic, I agree. So the patient has infection, patient has sepsis, patient has severe infection, respiratory failure, recovering ICU admission, and the recovery of the hypoglycemia correlates with the time at which the COPD exacerbation recovers. Another point is the seizures could be due to the respiratory failure per se. So for all the drug-induced causes, all the other negative factors should be more or less should be out, especially the sepsis. So how to say that it is drug-induced hypoglycemia exclusively?
No, exclusively we can't say. We are still in doubt. Yeah. But this patient required ICU admission only because of hypoglycemia, which was demonstrated, leading on to seizure.
But the patient was recovering BiPAP, I think.
Yeah, she was on home BiPAP for a long time.
No, there is no point to debate on that, sir. The issue is what is the cause of hypoglycemia?
Seizure, whatever be the cause for hypoglycemia, seizure is good.
Sure, so that is agreed.
So one mechanism of doxycycline producing hypoglycemia is hepatic failure. Here we have ruled out hepatic failure also. There was no enzyme elevation either.
And also it has some relation to the insulin, the cleaving mechanism.
There are different theories like increasing insulin sensitivity, but it's all theories. There are no clear-cut evidences to say this is the mechanism.
Because when the gatifloxacin came, even in non-diabetic, those who are outpatient, we used to see, this is 10-15 years ago, so we used to see hypoglycemia. That time we used to go extensively, then if other causes are found out, then we always exclude. So that is why.
Can you say Procal is? Can you safely say Procal is a bit overhyped?
Extremely well.
Lot of.
The guidelines are very clear. Procalcitonin, even in the Indian guidelines, is also procalcitonin is only useful to de-escalate antibiotic, never to start an antibiotic.
Clinical condition is more useful than Procal.
Starting of antibiotics always depends on the symptoms and the setting, never based on procalcitonin.
At this slide, except for one column, everything else said you start antibiotic, irrespective of whether it is less than 0.2 or more than 0.2.
So that is what there was talking in all critical care conferences. Patient admitted in ICU has infection, ventilator recommended. Who will have a guts not to start an antibiotic? Even the procalcitonin is negative. So that is a debate, and that was there in every guideline meeting. That procalcitonin is never useful to decide on starting an antibiotics and choosing an antibiotic. Always depends on the setting, the previous resistant factors, the previous risk for MDR bugs, as well as the syndromes. So it's useful only to de-escalate antibiotics. So if no more questions, so we'll move to
This case was published.
Yeah, this one. But they not raise the referees not raise this question. So very. Over to Dr. Kripa for her presentation on cryptococcal disease.
Probably Kripa can take steps to establish the concepts.
Sure, sir. Thank you. So, good morning to all. This will just be a short discussion on cryptococcal disease in diverse host. So, as we all know, cryptococcus is an opportunistic fungal infection, more often seen in patients who are immunocompromised. And typically it is defined in patients with advanced HIV disease to start with a low CD4 count. However, there's a changing paradigm in this disease, and we are now often seeing this disease in patients who are HIV negative. So even in immunocompetent patients, we do have these diseases being reported now. So we'll discuss about it shortly. Before that, we'd like to share with you a case that we had recently. So this was a 16-year-old adolescent male, a school-going child, who presented to our outpatient department with history of fever, headache, nausea and vomiting, and neck pain for almost 2 weeks duration. He did not have any history of seizures or limb weakness or bowel or bladder incontinence, and he did not have any other major systemic complaints. So there was no recent travel, sick contacts, no recent vaccination, trauma or animal bite. In the past, he was actually a known case of hypothyroidism and was on thyroxine supplements, and he was diagnosed to be probably idiopathic short stature. So he had an extensive workup by a pediatric endocrinologist, and he was on regular follow-up with her, and he was on growth hormone supplements for the same. The mother also gave a history of recurrent febrile illness. Most of the episodes were associated with upper respiratory tract infection, at least 3 to 5 episodes in a year. And there was also a history of fever with pancytopenia when he was around 4 to 5 years of age. He was admitted in CMC Vellore for the same, and extensive workup was done, including a bone marrow examination which was non-contributory. And apart from short stature, the other developmental milestones were normal, and vaccination status was appropriate for his age. So on examination, his GCS was 15/15, meningeal signs were present, he did not have any of the focal neurological deficits, and other system examination was grossly normal. On admission, our probable differentials were, in terms of infective etiology, we considered the possibilities of viral meningitis, and tropical fever was also considered, and we also considered the possibility of a partially treated bacterial meningitis because before he came to us, he was treated elsewhere as an outpatient, and he received a couple of doses of antibiotics including ceftriaxone. So chronic infections like TB and fungal were also in our differentials. And in terms of non-infective etiologies, autoimmune and benign intracranial hypertension were considered. Initial blood workup was sent. Empirical antimicrobials, including meningitic dose of ceftriaxone, vancomycin and acyclovir was started. Shortly, the labs were available. Hemoglobin showed 10.9 gram per deciliter. Total count was around 8,000. Significant lymphopenia was noted and platelets were around 1.9 lakhs. CRP was 5, procalcitonin was negative. Renal functions and liver function parameters were normal and tropical fever workup turned out to be negative. Ultrasound abdomen and chest x-ray were normal, and this was a CT brain which actually showed diffuse cerebral calcifications. So in quite some time, the child actually had an episode of fever, became drowsy, and so we shifted him to pediatric ICU for further care. And we also did an MRI brain immediately, which showed acute multiple lacunar infarcts with diffuse leptomeningeal enhancement suggestive of meningitis. We proceeded for lumbar puncture, and CSF analysis showed a total count of around 92, which was lymphocytic predominant. The protein was elevated, hypoglycemia was present, Gram stain showed occasional pustules and no organisms were seen, and CSF MTB gene expert was negative. Meningoencephalitis panel was also sent. So given the clinical presentation, we also had a suspicion of a possible underlying immunodeficiency. So we also sent for a serum cryptococcal antigen and serum cryptococcal antigen. The viral markers including HIV was negative, and the blood culture at the end of 24 hours was sterile. Shortly, we got an alert from micro lab saying the serum cryptococcal antigen was positive. So we started the child on liposomal amphotericin B, and because of non-availability of flucytosine, we started him on fluconazole. But in a couple of hours, he developed an episode of seizure followed by bradycardia. We had to intubate him, initiate him on bag and mask ventilation. Anti-epileptics and anti-edema measures were also initiated. But in spite of appropriate restorative measures, we lost the child. And later, we actually had the blood culture yielding a budding yeast identified by MALDI as Cryptococcal neoformans. So this was the blood culture which yielded Cryptococcus. And on a later date, we also actually sent for a whole exome sequencing, and it did pick up genes of SRP72 and USP, primarily something to do with the bone marrow failure syndrome. So when we talk about Cryptococcus, as we discussed, it's more often defined in a typically advanced HIV disease with a low CD4 count. So the geographical factors include where the endemicity or the disease burden of HIV is high, we more often see this disease. But nowadays, we do identify other species. Cryptococcal neoformans is associated both with HIV and non-HIV individuals. And Cryptococcal gatti was earlier thought to be more often associated with patients who are immunocompetent. But now we also see these species in patients who are immunocompromised. And occupation, of course, people who are involved with livestock, especially pigeon breeders, are at higher risk because the load is high in the pigeon droppings. And when we're talking about immunocompromised host, apart from HIV, organ transplant recipients are at higher risk, especially solid organ transplant when compared to stem cell transplant. And among organ transplant, actually kidney transplant carries a higher risk for Cryptococcus than the other organs. And people who are in immunomodulator therapy or biologicals, so corticosteroids predisposes the patient to develop cryptococcal disease, and TNF-alpha inhibitors, all these carries or predisposes the patient to develop this disease. And sarcoidosis, idiopathic CD4 lymphopenia are also known risk factors. In fact, we now have even uncontrolled diabetes and cirrhosis as known to cause this disease. So clinical presentation, when we actually discuss about this, it's almost a parabola, because in the left hand we have patients who are immunosuppressed. In them, the fungal growth is just uncontrolled, and there is a very little inflammation that takes place. So the treatment will then actually target antifungal therapy. Along with it, you will have to decide on the immune augmentation. So that is what happens typically in an advanced HIV disease. So because they are completely immunosuppressed, you have to improve their immune status, and that's where ART plays an important role. And the other spectrum is where the host inflammation is uncontrolled. So once the fungal load is cleared, what happens is the fungal antigens are being presented and the immune response is just exacerbated. So the inflammation plays an important role in the damage. So in such situations, along with antifungal, immune attenuation is what is recommended for treatment strategies. So in short, the points that we'll have to consider is, in advanced HIV, for time and again, we all know that it's a primary CNS disease that's more life-threatening, and iris is something that we'll have to always keep a watch out when we are talking about HIV patients. And in non-HIV, it needs a lot of a strong clinical suspicion to diagnose, to early diagnose this disease and start treatment. And post-infectious inflammatory response syndrome is what we see in a non-HIV host. And between species, in Gatae, we know it has a more predilection for lung than CNS, and cryptococcomas are more common with Gatae, and it has a predilection for visual center, so blindness is often seen in patients with Gatae infection. So it's a silent threat, but it requires a high level of clinical suspicion for earlier diagnosis and better management. And in spite of appropriate treatment, we all know that this disease carries a significant mortality. Thank you.
Thank you, Dr. Kriba. Any questions? So we see the time when we learned LPR only in cryptococcal meningitis patients during our undergraduate days. In medicine, after you rule out all this, the next important test that we do is CD4 in adults. So usually CD4, idiopathic CD4 cytopenia, we get it's a presenting disease. I'm sure in this patient, because of underlying hematological problem, the patient had cryptococcal disease because he had pancytosis for so many years. And we do see a cryptococcal lung disease in immunocompetent individuals. They present with mass, lung nodules. They carry with the diagnosis of CA lung, carcinoma lung. If you biopsy, then it correlates. The question to you is, the pathology shows cryptococci, and more or less what we have seen is the cryptococcal antigen is also parallelly positive. What is the positive rate of cryptococcal antigen when the pathology is being positive? Because we almost see both are correlating. One. Number two, the flu cytosine is a problem in our country because even we found it that it's very difficult to get it even in Delhi. So what is the access to that?
So the first question, serum cryptococcal antigen actually, it has a very good sensitivity and specificity. So both in HIV and the non-HIV population, I think that is one test which in case of high clinical suspicion, that is one test which will actually help us in ruling out the disease. So we also have, even in HIV population, it has been defined that even before the patient develops the symptoms or progresses to develop a CNS meningitis, the serum cryptococcal antigen turns out positive.
Non-HIV patients.
In non-HIV patients also, this has equally good sensitivity and specificity. So that in fact, in want of time, we haven't discussed about diagnosis and treatment, but in both HIV and non-HIV population, serum CRAG is one test that can actually help us in ruling out the disease. So that is the first. And flu cytosine, yes, we have difficulty in procuring the drug. So in such cases, we go for fluconazole during induction phase itself when we have a difficulty in procuring the drug.
Yeah.
Thank you, Dr. Kriba, for a good presentation. And my doubt is cryptococcal meningitis. See, those days we have been doing routinely this India ink preparation. After the LP and get the CSF, go look for India ink preparation also. But what's the confirmatory test? But the CSF results, what I had shown, still fits in. Even I can say TB meningitis. Because elevated protein, decreased sugar, elevated lymphocytes. Yes. Still I can say TB meningitis. Or I can say some other viral encephalitis. How to fix up its cryptococcal meningitis? Any confirmatory test? So CSF antigen?
A CSF CRAG was also positive in this patient, and cultures were also positive, sir, for this particular patient, sir. Cultures also yielded budding yeast, which was identified as Cryptococcus neoformans, sir.
Before starting treatment itself?
No, sir. We started based on serum CRAG, sir. Serum CRAG has almost 99. That comes earlier, within 15 minutes. Actually, we can get the testing, sir. Serum CRAG.
So another thing, of course, we do get. We were not now. We are getting this cryptococcal meningitis, amphotericin, but overall outcome was not good.
That's
at least in my cases. We had treated for 1 month, 45 days continuously with amphotericin, but overall outcome not that appreciable. What's your experience?
Yes, sir. In spite of appropriate treatment, almost 10 to 15% of patients were. And one more thing that can help in improving the prognosis is daily lumbar puncture. So the raised intracranial pressure is something that actually increases the mortality in this patient profile. So daily LP in fact helps in and it has proven to have a mortality benefit, sir.
Yeah, that's what your thing is good.
Practically,
Doing one LP itself is
practically
very difficult.
of course we'll have difficulties, sir. So
That's what doing one LP itself is very difficult. You have to convince so many people. Doing daily LP practically, maybe it's difficult, little difficult. Okay,
thank you, sir. Thank you.
Courses, they do well. They do well. So because we see often. So, Sridhar.
Madam, what was the diagnosis of pancytopenia at that point of time, at the 4 years?
Sir, actually it was all non-contributors, sir. Infect workup CMC well or full file irundhudu, but ana edume pick up alla, sir.
No, madam.
Actually they had we have yes, sir.
See,
But we don't know the significance. We in fact asked the patient's family to come back to us because they have he has a sibling, but they haven't turned up, sir.
Because why I'm asking you, madam, even now there's no significant neutropenia. The ANC is still more than 1500. So most of the time the fungal infections is prone, especially in the immunocompromised host or immunosuppression by any state. Only when the ANC is less than 1500, because the ANC is almost too close, because the neutrophils are more than 85% and the total counts are somewhere around 10,000. It's more than 8,000. So maybe unlikely for a fungal infection. Maybe the underlying second mutation, what was there? Some other mutation was there, no, madam?
Related to actually pseudo-hypoparathyroidism, sir. More of an endocrine. USP 18 related to TOT syndrome. But
because sometimes these inherited bone marrow failure syndromes can present late, maybe around even 20-30 years. We have picked up cases at 30 years of age also. But still, maybe because as long as the ANC is good, we don't suspect any fungal infection altogether. Upfront, maybe we would have got that.
Maybe here the CD4, it's basically lymphocytes that play an important role when it comes to disease, evasion, sir. So I think that is probably the predisposing factor, because earlier also when he had recurrent febrile illness, every time CBC was done, lymphopenia was noted. Even in this, it was only around 7%, sir.
7%.
Yes, sir, 7%, sir. So probably we don't have sample to do a flow cytometry to check for CD4 lymphopenia, but I think that is something that could have added more to really know what predisposed him to develop this disease.
HIV negative cryptococcal, next test we do is
CD4.
So thank you. And Dr. Sarvesan sir, we are waiting, aching to listen what is bones, stones, groans and moans. Over to you to break the news.
I'm presenting a case series on parathyroid tumors on behalf of Dr. Sarveshwaran sir, senior consultant and head of the Department of General Surgery. And my topic is bone, stones, groans and moans. This case series is based on totally 11 patients who were treated in our hospital. And out of these 11 patients, 7 were female and 4 were male. And out of these 11 patients, only 4 people belong to the age group of less than 40 years and 7 belong to more than 40 years. And based on our case series, most commonly involved gland is right inferior parathyroid gland, and that was followed by right superior gland, seen in 3 patients, and left inferior gland in 2 patients and left superior gland in one patient. Now we are going to discuss about few of our interesting cases. First case is a 23-year-old female presented with the swelling over left maxilla, which was treated outside as a dental abscess, came to the dental OPD of our dental college of Sri Ramakrishna Hospital. From there, they refer the patient to our OPD. On further investigation, she found to have elevated parathormone level of 2000, more than 2000, and ionized calcium level was 5.4. Ultrasound next showed a hypoechoic lesion on the left lobe of thyroid gland. And sestami B scan showed left inferior parathyroid adenoma along with multiple Brown's tumors also noted in left maxilla, right 8th rib, and lytic lesion in C4 L1 vertebra, and multiple Brown's tumor is seen in the pelvic bone also. And this is her CT scan of the facial bone, and which shows a lytic sclerotic lesion in the left maxilla, which extending to the roots of premolar teeth and roots of canine. And here you can see the lesion extending to the left maxillary sinus also. And the patient undergone surgery for left inferior parathyroidectomy, along with the enucleation of maxillary lesion with patient-specific implant, which was done by the OMFS team. And in the below picture, you can see the left inferior parathyroid gland, which was successfully resected, along with the 2 lymph nodes. And in the above picture, you can see the enucleated site of Brown's tumor. And post-operative parathormone level was significantly reduced from 2000 to 179, and ionized calcium level is also reduced from 5.5 to 3.8. And HP report came out as parathyroid adenoma, and the patient was on regular follow-up, and currently she is doing well. And case 2 is a 55-year-old female presented with the complaints of abdominal pain. She was a known case of recurrent TAA and recurrent ureteric calculi, and also a known case of primary hyperparathyroidism. Her parathyroid levels were elevated, which is 260, and ionized calcium level was 5.4. And her ultrasound neck showed hypoechocclusion in the right lobe. And CT system EB scan also showed right inferior parathyroid adenoma. CT KUB was also done, which revealed left renal calculi with mild pyelonephritis. So the patient underwent right inferior parathyroidectomy along with ureteroscopic lithotripsy with double J stenting of left ureter for calculi and mild pyelonephritis. And post-operative investigation showed reduced values of parathormone and ionized calcium levels from parathormone of 260 to 71, and ionized calcium reduced from 5.4 to 4.9. But to our surprise, her HPE report came out as parathyroid carcinoma with capsular and vascular invasion, as you can see in this picture. And the patient is on follow-up till to date, and she showed no recurrence. And case 3 is a 60-year-old male presented with neck swelling, anorexia and constipation. OGD scopy was done for anorexia, which showed GRD1 with duodenitis. His parathormone level was elevated more than 1000, and serum calcium level was 12.5 also. And ultrasound neck showed nodular lesion in both right superior lobe as well as right inferior lobe of thyroid. But system EB scan showed in favor of only right inferior parathyroid adenoma. And he underwent surgery for right inferior parathyroidectomy with excision of nodule in the right lobe of thyroid. And post-operative values of parathormone significantly reduced from 1100 to 161, and serum calcium also reduced from 12.5 to 7.7. And HP report showed parathyroid adenoma with colloid-nodular goiter and Hashimoto's thyroiditis. And case 4 is a 50-year-old male presented with renal failure and parathyroid adenoma with hypercalcemia, who was referred for surgery. His parathormone and serum calcium level was elevated, which showed parathormone of 560 and serum calcium of 11.8. And imaging studies, ultrasound neck showed hypoechocclusion in the right lobe of thyroid, and system EB shows the right inferior parathyroid adenoma, as you can see in this second picture. And patient underwent surgery for right inferior parathyroidectomy. The first picture is the preoperative one, and the second picture depicts the right lobe of thyroid, which when retracted shows the right inferior parathyroid gland. And post-operative was uneventful, and post-operative values were reduced from 560 to 16. Parathormone values reduced from 560 to 16.4, and serum calcium also reduced from 11.8 to 10.5. And HPE report came out as parathyroid adenoma. Case 5 is a 19-year-old female who presented with the complaints of pain in the left thigh for the past 1 week. She already has had a shaft of femur fracture on the right side following fall 20 days back, for which ORIF was done. As you can see in the picture, right leg showing the ORIF and the left leg showing the shaft of femur fracture. And her parathyroid levels were significantly elevated, which was above 2500, and serum calcium also 16. And so this is the system EB scan showing the right inferior parathyroid adenoma, and the patient underwent right inferior parathyroidectomy. As you can see, this is the right inferior parathyroid gland after retracting the right lobe of thyroid gland, and this is the specimen we resected in. And post-operative period was uneventful, and there was a significant change in the parathormone levels from which dropped from 2500 to 72, and serum calcium also reduced from 16 to 7.6. And HPE report came out as a parathyroid adenoma. And case 6 is a 39-year-old male who was a known case of neurofibromatosis and left parathyroid adenoma, which was diagnosed 6 months before outside. Now presented with the complaints of abdomen pain and reduced appetite and weight loss. On examination, we saw a palpable neck mass on the left side, and perabdomen was soft and epigastric tenderness was present. And he also had outside peak value of parathormone. So blood investigations were repeated, which shown elevated serum parathormone level of 270 and ionized calcium level of 5.7. System EV scan revealed left superior parathyroid adenoma. So the patient underwent left superior parathyroidectomy, and the post-operative parathormone level was reduced from 278 to 54, and serum ionized calcium decreased from 5.7 to 4.4. But here also HP report revealed it's a parathyroid carcinoma with multiple foci of capsular invasion, and CT thorax was also done to rule out the metastasis, which came out as negative, and the patient has been on frequent follow-up with no evidence of recurrence till date. And the last case is a 38-year-old female presented with abdomen pain, and on further investigation her USG abdomen showed pancreatitis, gallstones and renal calculi on the right kidney. Blood investigation showed elevated parathormone of more than 1200 and elevated serum calcium level of 13.2. Ultrasound neck showed hypoechoic lesion in the right lobe of thyroid, and system EV scan confirmed a right inferior parathyroid adenoma. So the patient underwent right inferior parathyroidectomy, as you can see in the first picture, where the resected right inferior parathyroid gland. The second picture depicts gallbladder, which was removed by open cholecystectomy. And here is your greater omentum, which shows intraoperatively the greater omentum showed saponification of calcium, which got deposited in the greater omentum due to acute pancreatitis. And post-operative blood investigations were reduced parathormone of 1200 to 12.7, and serum calcium was reduced from 13.2 to 9. And HP report came out as parathyroid adenoma, and gallbladder it showed acute on chronic cholecystitis. Now coming to the theoretical part of parathyroid adenoma, it is a benign encapsulated tumor. Around 85 to 96% of the cases of primary hyperparathyroidism is due to parathyroid adenoma. In most of the cases, only single glandular involvement is there. And coming to clinical presentation, around 80% of the patient will be asymptomatic if presented with symptoms. The classical description of symptoms will be renal stones, painful bones, abdominal groans, lethargic or psychic moans. And associated preoperative conditions of nephrolithiasis, bone tumors, fracture, pancreatitis and gallstones. And the basic biochemical parameters which we should investigate for is serum calcium level and serum parathormone level. And coming to radiological investigation, the first and foremost is the ultrasound, which is the most common one and inexpensive also, but it has an accuracy rate of only 70 to 80%. We cannot differentiate which parathyroid gland is exactly involved, and so we do a system EV scan, which is a more sensitive and specific one to localize the tumor. In our hospital setup, we do is a combination of use ultrasound neck along with system EV scan, and 4D CT is used in only cases of recurrent or persistent diseases. And intraoperative monitoring, which is not indicated in all cases. For example, intact parathormone levels are monitored in case of discordant imaging, or whether we are not sure about it's a single glandular involvement or a multi-glandular involvement. In that condition, we can follow the Miami criteria, where a drop in parathormone level after removal of the gland to the normal levels or more than 50% of the pre-operative values in 10 minutes indicate we have removed the right gland only. It also helps to differentiate between the removal of parathyroid gland or any suspicious lymph node removal. And we can also do differential venous parathyroid sampling to identify which gland is involved in case of doubtful cases. And types of parathyroidectomy is bilateral cervical neck exploration, focused parathyroidectomy, where the isolated gland will be removed, and radio-guided parathyroidectomy, endoscopic and video-assisted parathyroidectomy, and reoperative parathyroidectomy. Okay. The only localization that a patient needs who has primary hyperparathyroidism is the localization of an experienced surgeon, which was said by John L. Dobman. But due to recent advancement in radiological investigation like system EV scan, it is now efficient to localize the tumor. And to summarize, these are the presentation of our cases, the one presented with renal failure and 2 with renal calculi, and 1 presented with Brown's tumor, 1 with fracture, 1 pancreatitis and gallstone. Out of these 11 patients, 2 turns out to be a parathyroid carcinoma, and we also had 1 special case where presented as a where a parathyroid adenoma hyperplasia presented with the Men's syndrome. And the take-home message is, any patient presenting with a recurrent renal calculi, bone fracture or bone lesion, or any of the typical presentation, you should suspect for parathyroid tumor, and we should do the basic biochemical investigation like serum calcium levels and serum parathormone levels. And serum any parathyroid tumor can be potentially malignant even with the low parathyroid levels. So the histopathological examination will give the definitive diagnosis. The reason why I'm saying this is because both our parathyroid carcinoma cases are presented with low values of parathormone levels post-operatively, and these two cases were published by our department as a case report in International Journal of Anatomy, Radiology and Surgery on May 2023. And the special case which I told you, parathyroid adenoma presented with Men's syndrome, is also published as an article in the newsletter of Association Surgeons of India in November 2023. Thank you.
At this juncture, let me thank our associate departments like nephrology, orthopedics, gastroenterology, and other departments who have been regularly sending cases of parathyroid adenoma to us. Though she has told only 11 cases, but the numbers may be a little more. But we didn't have adequate data to show it here. And recently, yesterday, we had a case of parathyroid adenoma, which we are going to operate in next week or so. And I think surgical oncology people, they did a case yesterday, so we do get enough number of cases. It's quite rare, around 30 to 40 cases per lakh per year. And we just today focused only on parathyroid adenomas. So a high degree of suspicion is required, and not all parathyroid adenomas may be benign, it may be malignant also, even if the PTH is low. That is why our 2 cases got published in the last year. Thank you very much.
So we missed a new addition, sir. Actually, for yesterday's case, that we can do, sir. It is like a F18 choline bit. Choline bit. Because acetylcholine is a receptor in the parathyroid, sir, which we can image. So F18 choline every Saturday per month once. It's available, sir. 1 case we have done. So mainly in equivocal cases, STAMI scan is equivocal, we are not able to pick up, but in spite of the patient have increased PTH, we can go for this scan. Only cost. Yeah, choline. So like FDG. F18 is same, choline. Instead of fluorodeoxyglucose, they are tagging choline. So it is produced in Cochin. So we are getting monthly once. 1 case we did. Our radio here worked past radiographer. He was operated twice. And almost 8 years now. Now his PTH is again elevating. So he came all the way from Dubai. So we did a choline bit last month. First scan we had that.
We congratulate our humble but excellent surgeon, Dr. Sarvesh. It is really a great work indeed, sir. We still remember having read in Bailey and Love, bones, stones and abdominal groans. But gallbladder stone was never mentioned. Do you incriminate this gallbladder stone due to parathyroid, or it is per se another disease?
Somehow we got an associated in that case. We had a gallstone there, and he also had pancreatitis. So we had to remove the gallstone because that was the cause for the pancreatitis. You could have seen that saponification, that omentum was showing the calcium deposition. So it's very classical. So we combined parathyroidectomy with cholecystectomy, and this is the saponification where you can see that calcium deposition.
Yes, yes.
So all this calcium, so that is very classical of pancreatitis. This pancreatitis, it was actually referred from the gastroenterology department. Got admitted for pancreatitis, but on investigation they found hypercalcemia. Then they investigated for parathyroid, and that came as positive. And so we did both parathyroidectomy and cholecystectomy. And gradually it settled down.
And in
But I don't know, usually as you say, sir, this hypercalcemia may not be the cause for pancreatitis, but gallstone can cause pancreatitis.
Hypertension is one of the important causes of
cause for
Pancreatitis, yeah. So recurrent pancreatitis, we always investigate for parathyroid also.
we in pediatric surgery you get chronic pancreatitis. They eventually evolve into pancreatic deficiency and diabetes mellitus later. And is robotic surgery, what is the role, sir, for parathyroid?
Probably it's coming up. Just like thyroid. Other thing is video assisted. So all those I didn't go into surgical details because it's not a surgical forum alone. They do a video assisted parathyroidectomy where they put the ports in the axilla and take the endoscope inside. That is the laparoscope, same laparoscope from the axilla. So no scar in the neck. So cosmetically it's more acceptable. That is video assisted parathyroidectomy. That is from the axilla we have to approach. If it is the right side, we go from the right axilla. The same laparoscopic ports can be put here and taken there and done just like a video assisted thyroidectomy.
They also go through the nipple.
Yeah, that is nipple, and even endoscopic, that is NOTS, natural orifice transendoscopic surgery. Through the oral cavity, they go and do the parathyroid as well as thyroid. That is NOTS. NOTES, natural orifice transluminal endoscopic surgery.
No, sir. I think I'm audible. For the carcinoma cases, you had to go back and why?
No, we didn't do it. That's what we are just keeping them under follow-up. The literature suggests that only if they develop a recurrence or if they keep a follow on the parathormone levels. When the level starts going up, then we need to investigate again, do a system or something. If we pick up something, then we have to go in and do this. But if there's a capsular breach or if we feel that the capsule is broken or the invasion is there, then we have to go in again and then we have to do the thyroidectomy also. So that for completion. But these two cases we have not gone in. Yeah, that's what. So we have to keep a close follow-up and monitor the levels of parathormone. If they start going up, we have to investigate again, or else we have to. The pathologist says it's a capsular breach. Better to go in and do a clearance surgery.
Actually, the cancer biology, the cancer cells, they differentiate. Sometimes we do have a scenario like this. We see this even in less PSA secreting adenocase of the prostate. So whenever the cancer cells is de-differentiating, you will not get the original cell. From the original cell only, we will have all the hormones secreted. If there is a change in the cancer biology itself, the tumor gets de-differentiated, then all the level, which is the normal hormones has to be, say, will not come. So those kind of correlation we do see in cancer department. Exactly.
Okay, regarding first case, it was a maxillary brown tumor, was it? So, do we always require surgery for that maxillary tumor or?
some other
Brown.
Yeah.
some prostate.
Outside biopsy was showed odontogenic origin, sir. Outside biopsy was done. It's outside our.
No.
And the surgical excision biopsy
So
showed
it was an innocent bystander and not due to this. No, if it was due to this, we don't need to do surgery for that. Only parathyroid. And reconstruction can be done later after parathyroidectomy if it was a brown tumor.
Thank you, sir. So, if you have two adenomas, which adenoma you will decide to operate if you don't do intraoperative venous sampling of PTH?
The dictum is to remove everything. If you have doubt, especially in parathyroid hyperplasia, remove all four. And if you have a doubt, remove the thyroid also, that side thyroid. Right hemithyroidectomy plus the upper and lower parathyroids. So unless we are sure, otherwise better to remove both.
Thank you, sir. Good. So it's a Chapman service. Good Chapman services. So thank you and thank you. We thank you the Department of Medicine as well as Surgery for the interesting cases today, and we'll meet at the next meet. Thank you all.